Now here is a diagram showing the heme synthesis pathway and the related porphyrias due to the deficiency in the various enzymes. Succinyl-CoA and glycine forms aminolevulinic acid or ALA catalyzed by ALA synthase whose deficiency causes X-linked sideroblastic anemia. Further, we have porphobilinogen getting converted to hydroxymethylbilin via the enzyme hydroxymethylbilin synthase or uroporphyrinogen synthase, whose deficiency causes acute intermittent porphyria, the most common type of porphyria. Further down the chart, we have the other enzymes whose deficiency causes the related porphyrias, like congenital erythropoietic porphyria, Porphyria Cutanea Tarda, hereditary coproporphyria, variegate porphyria, and protoporphyria. Classification of porphyrias. Porphyrias can be classified into acquired porphyria and inherited porphyria. Acquired porphyria can occur due to liver disease, tumors, and toxic metals like lead, arsenic, mercury. Inherited porphyria can further be classified based on the site where the enzyme deficiency occurs. If it occurs in the liver, hepatic. If it occurs in the erythrocytes, erythropoietic. Here is a visual representation of classification of porphyrias. Now let us briefly discuss about the various types of porphyrias. Acute intermittent porphyria is a type of hepatic porphyria caused due to the deficiency of uroporphobilinogen 1 synthase or hydroxymethylbilin synthase. It is inherited as autosomal dominant. Major clinical features are abdominal pain and neuropsychiatric manifestations. Also, dark reddish colored urine is present due to oxidation of PBG. It can be diagnosed due to increased levels of PBG and ALA in the urine. Treatment includes heme or hematin infusion and avoiding cytochrome P450 drugs.
Now I'm going to speak about hereditary coproporphyria, which is a hepatic type of porphyria caused due to the deficiency of enzyme coproporphyrinogen oxidase. Its inherited form is autosomal dominant. Its clinical features are abdominal pain, neuropsychiatric manifestation, photosensitivity, skin lesion on sun exposure. It can be diagnosed in lab by the increased level of coproporphyrinogen in the fecal matter and the urine and the increased level of ELA and PBG in the urine during acute attacks. Its treatment is hematin, antioxidant vitamins like A, C and E, using sunscreen while you're outdoors and avoiding cytochrome P450 inducer drugs. Moving on to the variegate porphyria, which is again a hepatic type of porphyria caused by the enzyme deficiency of protoporphyrinogen oxidase. Its inherited form is autosomal dominant. Its clinical features are abdominal pain, neuropsychiatric manifestation, photosensitivity, skin lesions on sun exposure. It can be diagnosed in the lab by the elevated porphyrogen and ELA during attacks and increased fecal protoporphyrin and coproporphyrin. Variegate means mixed and it gets its name because it shows both the neurological and the cutaneous symptoms. Its treatment is hemin infusion on acute attacks, sun protection while you're outdoors and avoiding cytochrome P450 inducer drugs.
So next is Porphyria Cutanea Tarda. This is most common cutaneous porphyria, type hepatic, enzyme deficiency uroporphyrinogen decarboxylase, inherited form autosomal dominant, clinical features photosensitivity, especially on hands and face, blistering, fragility of skin on sun exposed areas as we can see on this picture, hyperpigmentation, hypertrichosis, which is excess hair growth on face, dark or reddish colored urine due to porphyrias. Lab diagnosis, elevated uroporphyrin levels in urine, plasma fluorescence, which is also known as Woods lamp, treatment, sun protection like using sunscreen or protective clothing, avoid alcohol and other triggers, avoiding cytochrome P450 inducer drugs. Next is Erythropoietic Protoporphyria, type Erythropoietic, enzyme deficiency, ferrochelatase, inherited form, autosomal recessive as well as dominant. Clinical features, photosensitivity, pain, burning, redness, and swelling of skin within minutes of sun exposure. No blistering, unlike Porphyria Cutanea Tarda or variegate Porphyria. Thickened waxy skin and scarring with repeated episodes. Gallstones and liver complications due to protoporphyrin buildup in severe cases. Lab diagnosis, increased free protoporphyrin in erythrocytes and plasma. Normal urinary porphyrin levels. Protoporphyrin is not water soluble. Fluorescence of blood plasma under UV light. Treatment, sun protection like using protective clothing and physical sunscreens.
Next, we have congenital erythropoietic porphyria, which is also known as Günther's disease. Type is erythropoietic. Enzyme deficiency is uroporphyrinogen 3 co-synthase. Inherited form is autosomal recessive. Clinical features are extreme photosensitivity, which cause severe blistering and fragility of sun-exposed skin. Red urine from porphyrin excretion causes staining of diapers. Hypertrichosis, which is excess hair growth on face and extremities. Erythrodontia, which is reddish brown discoloration of teeth under fluorescence under UV light. Hemolytic anemia due to porphyrin accumulation in RBCs. Splenomegaly, enlarged spleen. Lab diagnosis. Elevated uroporphyrin 1 and coporphyrin 1 in urine, feces and blood. Red fluorescence of teeth, bones and urine under Wood's lamp. The treatment is strict sun avoidance and protective clothing, blood transfusion to reduce erythropoiesis and porphyrin production. Bone marrow or stem cell transplant, curative in severe cases. The misnomer of porphyria. Porphyria is often referred to as vampire's disease due to the following reasons. First, extreme photosensitivity. Patients must avoid sunlight as exposure causes painful blistering, much like the myth that vampires avoid the sun. Second, skin changes and disfigurement. Severe CEP causes skin scarring, contractures, and erosion of facial features like nose, ears, fingers, giving a monstrous appearance. Red or brown teeth, which is erythrodontia. Teeth appear reddish brown and glow red under UV light, reminiscent of the vampire's bloody fangs. Fourth, red urine. Dark or reddish urine due to porphyrins is similar to the myth of vampires drinking blood. Fifth, excess hair, which is hypertrichosis. Excess facial hair in some patients may resemble the wild appearance of vampire of legendary creatures. Sixth, anemia and pale skin. Chronic hemolytic anemia gives patients a pale, bloodless look similar to the stereotypical vampire pallor. So, this was the causes that misnomer of porphyria. Thank you.
So, very good presentation, and hope you have prepared it as well nicely. Any questions, sir?
No, question one, I think they have covered everything. One point, you can bring the first slide, acute intermittent porphyria, the investigation part. That slide you bring. One thing I would like to comment one thing about that. এটা যাও পড়তে যাও অ্যাপিয়ারেন্সটা যাও ইনভেস্টিগেশনে যাও ইনভেস্টিগেশন পরেরটা দেখো তুমি একটা ইনভেস্টিগেশনের জায়গা দেখেছিলে ইউরিনের কালারটা কোথায় আছে দেখো তো একটা জায়গায় দেখেছিলে ইউরিনের কালারটা না 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 একটা জায়গাতে দেখালে না ইউরিনের ডার্ক কালার ডার্ক টু ডার্ক রেড কালার কোথায় দেখালে যাবে হ্যাঁ দাদা একটু যাও কোন জায়গায় ল্যাব লিব্রেরি একটা রেড কালার দেখালে দেখো কোন জায়গাতে রয়েছে একটা আগেও anyway one thing I would like to say that I have never seen a case of acute intermittent porphyria so far. And I did not see basically. There was a case of acute abdominal pain mimicking something like acute intermittent porphyria. The patient was admitted in the medical ward and all necessary investigations were done. Urine was found to be reddish in color. But unfortunately, on repeated investigations, no RBC and neither hemoglobin was found. Finally, this sample was sent to biochemistry department for testing of porphobilinogen. Actually, we had that reagent at that point of time. It was something a story of 1993. Now, there was again an industrial hospital and there was a hue and cry regarding the diagnosis. The doctor failed to diagnose the case. Ultimately, the senior doctors contacted me that, how can you throw a little bit light on this? After I also did the same test twice. No, it was not coming out to be negative. No, porphyrias. I went to the ward, asked the patient directly to pass urine in front of me and told the senior persons waiting in the doctor's room. Now the patient started hesitating that I will not pass urine. Why not? You have to pass urine in this test too. Now ultimately what happened, the patient divulged that the patient brought a little bit of beet juice every time. Their relatives used to supply it and they used to mix a little bit of one drop, less than a drop of beet juice into the urine on top of which she used to pass urine. And that sample was being sent. Obviously, he was caught red-handed with that beet juice. Then I said that, why did you do it? The patient was transferred from Durgapur steel plant to Bokaro steel plant. And somebody from medical field has actually properly trained him to mimic acute intermittent porphyria and camouflage the diagnosis. This was a masquerading effect, and you will be seeing such type of cases in future, maybe rarely once or twice in your lifetime. You must be very much aware of all these things about camouflaging type of samples. Patient will do some mischiefs and they might mimic the real disease what we describe, but we cannot diagnose the case properly and they will start creating problems. That's it. First of all, congratulations to all of you. Those who have performed well, special congratulations for them, and they who could not, I am quite confident that in future you will be also master orators because it requires passion and perseverance. In fact, some of you have presented, if I interpret and self-criticize myself, that some of you have presented in a better way than what I usually deliver lecture even in conferences. So I really congratulate you and appreciate your presentation from the core of my heart. This was a small step of giving an opportunity to you, and this small step I anticipate and I wish that it will turn into leopard's leap in the long run, and you will be visible at the international forum in the years ahead. Third and most important point I have noted that none of you have actually covered what was taught in the class. During your presentation, you have copied from somewhere else. There are many things our teachers have told, including myself also, but you have ignored all those things. Remember, all teachers prepare well before they come to the class, and literally you have ignored it. That part you must not do in future. Because today I feel at the end of the year, my entire 1 year lecture, all the lectures went to waste and to the dustbin. Because I could not find any of the references what I told you. So it indicates clearly that if you really are sincere and spend enough time, you can self-educate yourself, and that's what you have to do, because nobody will teach you throughout your life. You have to learn yourself. You have to educate yourself. You are no more a child. You are an adult. That remember this thing. And one thing you are missing, I am telling you, you are endowed with a galaxy of talented and experienced teachers. You try to collect the nectar from all of them, because this opportunity you will not get once you leave the organization, leave this institution, and at that point of time you will realize what mistakes you have committed. So I once again wish that you excel well, much more than what is expected, and stop indulging in cross-talking, in gossiping. I end with a quote of Tagore's song. তোমরা এতটাই গল্প করছিলে এতে মনে হলো আমার যে আমার এতার বাঁধা কাছের সুরে ওই বাঁশি যে বাজে দূরে গানের ডিলার সেই কিনারায় যোগ দিতে কি সবাই পারে। তোমরা নিজেরা এতটাই গান গেয়েছো যে এখানে টিচার কি বলছে সেদিকে খেয়াল রাখবে, এটার জন্য পূর্ণভাবে একটু না হয়, এটা তোমরা খেয়াল রাখো।